Hi, everyone. This is the Para Podcast. Thanks for tuning in one more time. Today, we have a special guest. His name is Benson Kamau. We'll call him
Kamau.
Kamau.
Yes.
I apologize.
Because Macau.
Kamau. It's the other way around. Kamau. And we are pleased to have him. And to those who came to check out Elias, he's not here today. He's busy doing life things, as you know him. He's got a lot of hats that he wears, so he's wearing another one today. And today we have Benson Kamau and also Tulani Sibanda, the usual suspects. We are going to have a chat with this gentleman who is on some other parts of the world. I'll let him tell us where is he at the moment. Where are you, Ben?
Thank you. Thank you for having me. Thank you. I am happy to be here to speak about this very important conversation. And I am in Germany. I have been here for about 7 years now. And I came trained as a paramedic and now working as a paramedic here.
And where are you from?
And I am from Nairobi, Kenya. Yes, and I have conducted research about emergency medical services in Kenya. I have a lot of interest in this subject, specifically in the African context. And that is why I conducted the research in Kenya, my home country. And interesting insights. So I'm guessing we'll get time to talk about it.
So before we dive into that, how do you say, is it Guten Morgen or how do you greet in German?
Yes, Guten Morgen would be the correct greeting for me right now because it's in the morning. Okay. On your end, it's in the afternoon, right?
It's still in the morning, 11:45 a.m.
In Australia, it is 7:15, so it's afternoon.
For you, Malusi, it would be Guten Abend.
Guten Abend. Yeah. Okay. Now, I'm fascinated by this. Mm-hmm. You left Kenya. Yes. I'm sure you are bilingual.
Yes.
Speaking Swahili and English. Am I correct?
Yes.
Is there another one that you had?
My mother tongue, Kikuyu.
Okay, so 3.
At home with my parents, I would speak Kikuyu. When I go to the city in Nairobi, I would majorly either use Kiswahili or English. And German, I learned German and French at the university, although I concentrated more on German than French. So my French is not so good, but my German is good, and that is my working language here.
Yeah, the power of languages. Then you find yourself in Germany, working in Germany as something that you've never studied before.
Yes. And yeah. The surprising thing is that it is different. If you learn the language outside the environment you use it in is different from when you learn it in the environment you use it. Because I learned the language and when I came to Germany, you want to have a conversation with someone, then realize, oh, they have an accent. It sounds different from the book German, So you may understand the main ideas, but you have to listen keenly, especially if they use the accent. The region I work in, they have an accent or it's a different dialect. Let me say it's a different dialect. And you have to listen keenly because some may not be able to speak in the German textbook that you learned because that's what they are used to. That is what they speak. And so it has been a challenging time to adjust and to grasp the different dialects, but I can now confidently say that there's no information that bypasses me.
Number one, that's the greatest. I think to everyone who's listening, and this part is very important if you're planning to leave your home country, whether you're going to a country that speaks English or uh, Kiswahili or Germany or Arabic. Um, you are going to learn something new about that specific area. There is a culture that you don't know about that you need to adapt to. It's one of the things that I found as I moved to Australia, that I had to understand their language and how they talk and the meaning behind just keeping quiet and looking at you, the meaning behind saying something in a specific way and tone. It's just amazing because it's a lot of learning. Anyway, one of the reasons, or the main reason that we're here, I saw on LinkedIn, there's a paper that you posted. I said, this is interesting. I know that we once spoke to a doctor, Dr. Ben Wachira, and he sort of gave us a good perspective on what is happening in Kenya with regards to emergency medical care. But he mainly focuses in the hospital setting. There is a lot of stuff that he does in the ambulance, in the pre-hospital setting, but it's nice to know that a paramedic has done research too in this space. So we want to focus on your paper and understand what your paper is on about. For everyone, the paper is actually published. I think it was published sometime. Is it this month? Really, December?
Yes.
Yeah, 3rd of December. And it is titled Needs Assessment and Contextual Analysis of Public Emergency Services in Nakuru County, Kenya.
Yes.
Yeah. So that's the paper that he did, Ben did. And you did this for your master's, is that correct?
Yes.
Congratulations on getting this published. We love that. We'd like to hear good stories, not good stories, but stories that come out of Africa that are researched so that it can inform the policy. One of the people that we're targeting this is the people that are leading in Kenya so that they could understand what they need to do to reach a certain level that serves the people as equals of the global world, as not just the people from Africa and people from Nakuru County. All right. Why this topic?
So there's a story behind this topic, and
I want to hear it.
As I mentioned before, I work as a paramedic here in Germany, and so the experience I gathered here is very insightful. And I asked myself, what would be the situation in Kenya? So on 21st of September 2021, I responded to a road traffic accident. It was a collision between a motorbike and a car. The car was about at 50, the motorbike at 70 kilometers per hour. And the whole story short is that within maybe 45 minutes, the injured persons were taken care of, emergency care at the scene, and transported to the facility, the receiving facility. And the system functioned so well such that the injured person have a chance of survival. Now, fast forward 3 months later, I went to Kenya, and interestingly, and also sadly, the same situation played out. Motorbike versus a car, maybe at different speeds, but almost the same speed. And the whole story short is that the injured person, the motorbike person, passed on a few days later. I came to find out it's the same scenario, but one has a chance of survival, the other one no chance of survival. So it made me curious to find out what is our capacity as a country to responding to such emergencies. And then I came across a very robust medical care, emergency medical care policy done by the Ministry of Health in Kenya. And it is very aspirational. It is very detailed. It has everything that a country needs. on paper, but on the ground things are different. So I think in the policy, the government also admitted they are not aware of what capacity they have across the country to understand what do we have that enables us to respond to such emergency. So it is that whole story that inspired this study. And I chose Nakuru County because traditional research has focused on on the capital city, Nairobi. And if you understand very well, across all countries, resources are concentrated in the capital city. So there's limited information, knowledge about what other counties, what other regions can do. So Nakuru represents a good balance of urban and rural because it has almost 50% of people living in urban and rural. And it is the third most populous country, and therefore its characteristics it's easy to say that those would be similar conditions across other regions. Yes.
So before we continue, I just have a question here. Obviously,
Yes.
in most cases, Ben, is that research, just to be contextualized it in emergency medical services, is that it often begins with identifying what is currently happening in practice and determining the needs or gaps within the system, which is, I think the idea came from that, is that you've had international experience, and then you decided, okay, let me conduct a needs analysis to help clarify what are the existing challenges that can inform the priorities or guide the development of relevant research questions. But the one thing I want to ask you is, because I'm trying to find a link, when you moved to Germany, were you already a paramedic, or what inspired you, and also what inspired you to do paramedicine in Germany, whereas you didn't do it in Kenya?
So when I came to Germany, I wanted to gain technical skills and I looked around at what Germany had to offer, and the option that I could relate most with my personality, with my character, was becoming a paramedic. And that is how I ended up taking up the paramedic training here in Germany. And one thing led to the other, and I ended up at the university now focusing on that. Yes.
Yeah. So so you did the whole study, the degree in paramedicine. Is that what you did?
Yes. It is not a degree, it is an apprenticeship. So you go for 3 months for training in school, then you go for the next 3 certain period of time to the next station of learning, which is anesthesia. You also have the emergency and casualty department, the ICU. So it's a rotation of several stations. So it is always a balance of school and practical experience, theory and practice.
Okay.
Yes.
And how long is it?
3 years. 3 years.
All right. And then do you do internship after that, or you just jump in and work?
No, after that you just jump into the work because as in the process of studying, you are already exposed to the real work. I think my first day, I think the first year we went for 3 months of school, and then 3 months at the rescue station. And I remember the very first case we had was a resuscitation, and we had just learned the basic. And along the way, all the time, I asked myself, okay, I know I've been taught this at school, but is it time for me to start doing this already? Yeah. And the good thing is that you're not there to make decisions as a learner. You're there to make use of the learning that you have done, and there is a professional paramedic and a helper as well basically there are two people who could work out that call very well. You're just there to learn firsthand, and it is I could not imagine a better way of learning, because they say it's learning by doing, and it is very practical. Yeah.
All right. And is there registration with the council?
The registration with the council to become a paramedic, or
yeah. So what happens is, in other countries, South Africa and also Australia and the UK, once you finish your university qualification, you then have to register with a specific council that protects the public, but ensuring that you are registered to yourself. Is there anything like that?
Yes, there's something similar. It may not be exactly the same. Here you do something called a state exam, and once you do the state exam, you're registered automatically as a paramedic by the state.
Okay.
Yeah, and you're not limited to that state. You can also practice in other states.
All right. Sounds good. Yeah. Sounds good. So let's go back to the research. The Nakuru County has about 2.1 million population, and it is divided into, I'll say, it says on your paper there, 51.6 rural area, and then 48.4, which is the urban setting. Now, you did research, and that was the area that you picked. And then you did a research method that is interesting. It follows pragmatism. So you looked at two methods, qualitative research and quantitative research. Which one was your favorite?
I am more inclined to, even outside this research, I'm more inclined to quantitative method. But it was interesting for this one to combine stories and numbers, especially because you want to verify that the stories that are being told also reflect the numbers that are there. So it was very interesting, yeah.
I like the stories and numbers analogy. All right. And then after that, I wanted to also find out, once where did you get the sampling for the quantitative research? Did you do the people that you sampled for your qualitative research, and then you went ahead and then did the quantitative research on them? Or is that the strategy that you took?
They were different, because the ones that I used for quantitative research informed a different objective. So
okay.
The ones from the quantitative research I did mostly of purposefully sampling and snowball sampling.
Yeah.
Yes.
Okay, you said that is a qualitative research, or the quantitative where you did the purposeful sampling.
Okay. For the qualitative part, I also used purposely sampling, because I needed people with certain experience, with certain knowledge, people I knew who would have the information that I require. Yes.
Okay. So tell me about it. So you then decide this is the topic you're doing, this is how you're going to sample this. And I noticed that you actually went there to all these places within a certain period of time. And then did you have to knock at the people's, I'm talking about recruitment strategy now, knock and say, hey, my name is, so you're not known in the area, you've never been a paramedic. How did that experience go?
It was a mix of feeling, reactions, and also an amazing experience, because there are certain doors you knock on and you're received very well. There are certain doors you knock on and at first they are skeptical about you, but if you explain your story well and why you're there, then you manage to convince them. So it is not easy convincing people to onboard and help you do the study. It requires a lot of patience, and I think every researcher should be prepared for that, because you could also recruit people to participate in a study, and midway they say, you know what, no, I'm not available today. I know we talked about meeting today, but I'm not available today. And
Yeah,
probably you've traveled long distances and you've made sacrifices, but then you wouldn't you have to remain very professional and try to reschedule. So it is interesting.
Sounds good.
I wouldn't hold, as you said, we shouldn't hold it against them, but the amount of that you, in all honesty, it's frustrating because there's so much work that you put in behind, and the main things is time.
Yes.
There's other things that you need to do. There's work. Also, you're under pressure. I can imagine for you, you're also in Kenya. You have to finish your research within a specific time and then travel back to Germany. So all of that puts pressure. But I like what you said is that you have to try and remain professional, and eventually you'll get what you want. One thing that I found is that what Melis mentioned on your paper is 2 million people in Nakuru County. It may sound like a lot, but when I compare it to Johannesburg, where I'm from, I think the population is double that, maybe 4.84 million, somewhere there. And it's interesting that in that population, there is different aspects into what the people, like the type of conditions they have, it's presented in the paper. What I want to ask you, and you sort of like answered it, is that how are people, as a researcher, your experience in Kenya when you conducted your research, were they receptive towards research? Do they understand the importance of research when you went and did it there? Or they were like, no, we don't want to do it. Or then they don't understand the importance of it. Because from someone who is, obviously when I was a student, I didn't understand the importance of research. Is 10, 20 years later, 15 years later, my understanding of research and the importance of it in terms of policies, informing guidelines, changing the EMS community, not just from where we're from, because what you've written, it's not going to affect Kenya as well. Globally, it will have an impact. Somebody will see, okay, this is the paper. Maybe I can adopt, I can do it in my home country, especially in those countries that are from low to middle income countries.
Yes. I would say the people I interacted with were positive about research, that it has the potential to bring change. What they were skeptic about is whether the people in charge of decision making would be willing to read, to listen, to accept the outcomes and do something about it, because it is one thing to have all the information, and it is another thing to translate that information into decisions. I remember one person who was maybe a bit skeptical about it said, we have always done research, but they never read, they never look at it. So it is again on the researcher's part to emphasize the reason for it and why it would make a difference. The decision makers I got a chance to interact with were also very positive about research. And they said that if the paper is out, I should share with them, which I did. And I'm hoping that some of them would maybe give a feedback or write a feedback about it, or maybe see it being implemented. Yeah.
Yeah. So to anyone who's watching this who is in Kenya, I would encourage that from now onwards, this part, share it with your supervisors or anyone who's watching who might be interested. I've never worked in a system that is similar to this in terms of the challenges that you have. And I need to say that, yeah. I think now we are going to go to the themes that you found. You've got 6 themes that are there, and these are the challenges that you found in Nakuru County. And I would like us to go through them one by one. The first one is infrastructure and resource deficiency. Tell us, what does the title mean to you? What did you find there around that space?
Infrastructure deficiencies, we are talking about all the things that make up an emergency medical services system. Is it a dispatch center? Is it the fleet of ambulances? Is it what they have on board? I looked at all these aspects, and in as much as the ambulances were not adequately equipped, there is some effort by the county to improve on certain aspects. Talking about a dispatch center, the county is currently, I'm made aware that it is currently in the process of establishing a dispatch center. And this would really help coordinate the calls and the response, because right now the response is very uncoordinated. You go to respond to an emergency and you have very little information. So I think on the part of infrastructure, the dispatch center plays a very huge role. At the ambulances, they are there. However, in the words of one researcher who mentioned that ambulances are like matatus. Matatus are public transport buses that are affordable and move people from point A to point B, meaning that these are vehicles that do not have the equipment on board.
Just a taxi, basically.
Yeah. Yes.
Yeah.
They do not have the equipment on board, and also to look at the vehicles are also inconsistently unavailable, because it could be stationed at point A, but because today point C does not have one, it is relocated to point C, so point B remains empty, and a lot of unstructured, uncoordinated movement of these resources here and there. So, and also broadly speaking, to look at infrastructure, even though this may not be the part of the emergency medical services, but the road network, you find that the proximity to the next hospital could be 15 minutes away, but because the road is so poor, that distance can be covered in about 30 minutes. And in emergency medicine, time, minutes could be the difference that decides between life or death. So these are aspects that are very that put a dire situation of the system, and there would be definitely need to improve on that.
There's something that I found when I was reading your paper. It says that the ambulance stations are not there, so the ambulances are stationed at the hospitals. And you mentioned that all the hospitals, all the regions in the Nakuru area actually have hospitals, and then you said that they have each an ambulance. Some others may have 2. But the other issue is that you're mentioning now, I like that you're saying that there is work that is done towards building a control center or a dispatch center. But what I read on your paper is that there is no a dispatch center. So if a person calls, sometimes it rings and rings and rings and no one answers. Sometimes a person has to run from somewhere else and answer the call. Once a person leaves and goes to treat a patient, there might be no one who's answering on the other side. So basically, there is no infrastructure for communication, whether with the ambulance, whether with the population. So it's just not a system that is functional. That is what I got.
It is not a system that is functional. The dispatch is there. It is being set up now, so it is not fully. It is not operational at all. Not even fully. It's not operational.
I like your patriotism. Yeah.
In research, in as much as I love my country, I also have to remain very objective because there's no point of doing research if all I will come here is glorify how beautiful my country and my county is. So this is what a normal emergency situation would be in Nakuru. And maybe I should mention that the emergency medical services in Nakuru do not do primary response in the sense that someone calls from home. We have a case of a stroke. We have a stroke case at home. Can the ambulance come to my home to respond to this case? Nakuru County has not gotten to that point. What happens is that they majorly respond to road traffic accidents. And this is a normal response would look like an accident has occurred somewhere, and then a bystander or a family member or anyone in the community makes a call. And the call is not to the dispatch center because it is not there. That would be the ideal case. The call would be maybe to a trusted person, someone of influence in the community, or even the police. Because in the absence of the dispatch center as a communication and coordination pillar, the community now looks for any other option that is there. And it's usually a lengthy process because even if the hospital number is there, it is not a standard number. It could be a personal number of maybe the nurse who works there. On that day, they could be taking a leave. So you call them and they are not responding, or you could call and the person who has the hospital number is busy in the ward and is not able to respond immediately. So there's a lot of time that is wasted in between. Then the next step would be, let's take an instance, someone has responded to the call. So the next step is now to organize. Someone should authorize for the ambulance to leave the facility because it is attached to the facility. Now you start looking for the person in charge of the ambulance. You give them the story, and then they decide on whether the ambulance is dispatched or not. And by the time all these conversations have taken place, probably 10, 20, 15, 30, or even an hour has gone by. And then the point comes for the vehicle to go out. I think there was one station that mentioned, okay, we have an ambulance, but at the moment it is not working because we do not have resources to fuel it. So that's another challenge also because it could be there, but it cannot be dispatched. So,
Yep.
yes.
No, you can continue. Sorry.
Yeah. And all this environment is for lack of a better, is very chaotic. And for this system to work, the community has to trust that there is a number that I can call, and if I call this number, there is someone who will come. So that's the challenge.
So look, I think just two things from my side is that there's the the challenges that you spoke about, especially with the first team, the infrastructure and resource deficiencies, is
Yeah.
that it's when you look at the emergency care system framework
Yeah.
that was put forward by the World Health Organization.
Yes.
They've published multiple papers regarding the. I'm sure you've also seen it. Is that
Yeah.
it ties into part of making a system to function. And
Yes.
if you don't have that infrastructure, if you don't have resources, that affects. If you look at the emergency care system framework, it speaks into having a national call center that
Yeah.
will be able to communicate with the public to the emergency care center, and then the emergency care center sends the calls, the messages to the paramedics. And then
Yeah.
also you need ambulance services that will be able to go and respond to that. So I think what you said is that it highlights the fact that the system, if it can be built, should be maybe look at the model that has been already existing and then
Yes.
try then contextualize within the country that
Yes.
it is existing in. But the I think when we had Dr. Ben
Wachira.
Ben
Yeah.
Wachira, he
Yeah.
did mention that there is an excuse me, sorry, I've got flu. There is a plans to make sure that they've got a national number that everybody calls in case
Yes.
of an emergency. And the thing is, and this is from a personal experience, is that I honestly didn't know the importance of having national emergency line. I didn't know. But with experience, you get to realize, with experience, with the conversations that we've been having on the podcast, you get to realize that the importance of having one national number where people can call, even also the challenges that other countries are encountering. I must be honest, is that when I was in South Africa, I never actually researched about it. But
Yes.
whereas when I'm in the other side of the world, I get to realize that what's happening in other countries, and
Yeah.
it's important that we're very hopeful that things will change for better, because
Mhm.
it's not only us as paramedics. I mean, I'm saying us because I'm in
Yes.
solidarity of the people in
Yes.
Kenya or everywhere else
Yes.
that suffer, but also the people that are at our hearts, the patients. Yeah.
Yeah.
Hmm. Yeah. I think in South Africa we have 10177, which works. It goes directly to a control center,
Yes.
depending on the province. And then there's 112, which is on the cell phone. I've never used it, but I believe that it can take you to different um, ambulance services depending where you are. But also, then we have the small private ambulances that will have their own personal numbers. You've got your 02911 or 084124, and there are others that are longer, that I can't recall. So there's a whole lot of them. But well, I know them because I'm part of the system. Other people know them because they have medical insurances and stuff like that. Anyway, I want to continue. You've sort of touched on the second theme, which is human resources. You mentioned, I think there's one of the participants that mentioned that sometimes they'll be working in maternity ward, and while they're working on a person in maternity ward, they get a call, they have to leave there, and then they have to go. And then once I wonder what were they picturing when they were saying that, possibly delivering a baby or dealing with a PPH or whatever that they're dealing with in maternity ward, and then they have to rush for an accident. And then when they come back after driving and dropping the patient in hospital, they have to go back there and work. So that also spoke to them being fatigued, and working double tasks. It's sort of like a big responsibility. I think using nurses as people that work in the ambulance, I think is fine as long as they work there directly and they're trained to be in the ambulance. I think from where I stand, It's something that is engraved in the culture of the ambulance service in Kenya right now, that nurses will be there. But the issue is that they might not have training to work in the ambulance, which is a problem. We have people, I definitely know, I have seen a lot of people doing dual degrees. For example, they'll be doing nursing and paramedicine, and then at the end, they'll finish with both of those degrees, and then they choose which pathway they want to take. So it's okay that way, but they have to be trained. They have to be trained to work in the ambulance. It's a totally different setting. It's a different career altogether. I don't think that a person, because they work in hospital, it means that they can work in the ambulance. How did you feel about that space, the human resources theme?
It is a very challenging issue because and nurses are highly skilled people. They are highly skilled professional people that have been trained majorly for inpatient care. But now we want in Kenya to use them, or in Nakuru to use them in a different field. They are trained to work in a structured, controlled environment. And now we want to use them in a very unpredictable, protocol-free, so to say, because it is the situation now. They are used to protocols in the hospital, and the EMS is not so developed that there are protocols in Kenya right now. And it's also an environment where they don't have the immediate attention of a doctor, because in inpatient care, if there is something, you always have a point of reference. But now we are putting them in a new environment that they are not trained in, and they are expected to function, to work. It's very challenging because one of them mentioned that it would even make them doubt their capabilities, because you're suddenly at a scene where you are overwhelmed with what decisions to make, because you're not used to making those decisions. And all of a sudden you have now to make those decisions. So there would be no problem in using them as long as we have trained them for the work that they would be doing.
Yeah. I think we sort of touched on a lot of themes, not following them one by one. The first one was infrastructure and resource deficiency. The second one was human resource challenges. And after that, there was training and professional development needs. And then after there's psychological and physical risk, which involved them jumping around between hospital and driving the ambulance and then coming back to work again. And the one that we haven't touched much is the community engagement gaps. Now, on that one, I think what I found when I was reading your paper is that you mentioned that people are not trained to do first aid. People don't move when the ambulance is making noise at their back when they're driving, and they just keep on driving in their matatus going home and not worry about the ambulance that is making a wee wee sound. Yeah. Yeah. So that takes us to, is there any comment that you wanted to make around that last theme, the community engagement?
Yes. Initially when the ambulances were introduced into that county, there was a perception from the communities, and this is what they reported, that it was only meant for maternity cases. So anything beyond maternity issue is not an ambulance issue. So ordinarily what they did thereafter is, if there is an emergency, a road accident, they call the police. So it is the police now who have to organize on how to get an ambulance. So, and then there is also an aspect I mentioned earlier of trust. If they have the hospital number, but then you call the hospital number and eventually no ambulance shows up for whatever reason, no fuel, it could be somewhere else. if it does not show up, then that erodes the trust the community has on the system. And so for future emergencies, the community would not pick an ambulance option. They would probably look for a taxi or a friend to ferry the sick person in hospital. But that's not the essence of having a system if we are not going to make use of it and help the community. So the trust issue has to be there, and also the awareness to the community that these are the resources that the county has, and this is what they are meant to be used for, and this is how best you can access them.
So for me, sorry to jump in there, is that community education about emergency medical services is, I think it's absolutely essential, because of it ensures that the entire chain of survival is complete. When the public understands how to recognize emergencies, activate EMS systems correctly, and also to a certain extent where they can provide first aid or engage with the responders, the outcomes are of the patients, whether trauma or medical, are improved dramatically. And educated communities, they're more confident and more responsive, and they feel more empowered to act in critical moments. And the thing is also, if you look into research, let's not talk about specific countries, is that community engagement is still an important factor, and I don't think it's done enough, you know. And why do I say that? Is that people think if you've got a headache, you can call an ambulance. If they don't understand what the emergency is, in most developed countries where the EMS is quite developed, whereas in your country is that the community doesn't even have an idea that you've got ambulance services that can cater for critical patients that need to be transported to hospital, that need that need an ambulance to treat them and transport them to hospital. I mean, in the para podcast, we've looked into, you know, in advanced emergency care systems where they've brought into community paramedicine, into palliative care, emergency medical services. Whereas in Kenya, my understanding is that there's still that needed basics for addressing the community needs. And part of it is, I like that there was part of your themes that community engagement is important. And I hope that when this episode comes out, that the community can also reach out to find out what can we do in case of emergencies, and the stuff that we've spoken over and over again here in the para podcast about community engagement, that we should be engaging with the community to even like a simple number of what who do you call in an emergency, you know. But yeah, that's I think that's my comment on it. And as I said, I like the fact that you've put it as a theme. Just out of interest, is that when you came up with that, can I assume that the community engagement aspect didn't come from the community themselves, but it came from the participants themselves saying that there is lack of community understanding of emergencies?
It came from the participant based on their interaction with the community.
Okay.
Yes.
So I guess then just my last comment, Malus, is that I think there still also need to be, maybe it doesn't have to happen in Kenya, but somewhere else, is that there is the needs analysis to find out from the community what do they think about emergency medical services, because that's something that is not explored, you know.
Yes.
Well, I think in all emergency medical care systems or ambulance systems that are there in the world, there is always an opportunity to learn and develop. Even here where I am, the community does need to be engaged in certain things. and certain behaviors that sometimes not really warrant an ambulance, yet they still call an ambulance. So it happens. So but now on the flip side, in Nakuru County, people seem not to know when they need to call an ambulance, or if they need to call an ambulance, or actually if they need, or who do they call as an ambulance? So it's the challenge that is there. I think for the government is like the giant of healthcare system, is the giant in terms of the healthcare system. The private sector needs to be just supportive. So they need to show their muscle and show their power that they are there, not on paper only, but physically there. As much as the policies are there, I think that they need to start acting now. And I think it's about time too that the African people are taken serious as African people. There mustn't be different types of healthcare systems. Like, the people in Africa deserve the lower standards. There should be equal healthcare systems, because the value of a human should be equal. We shouldn't be saying that we want to be equal in the world, yet the governments that we select or elect do not take us serious. We should be taken serious by our governments, and they should create those systems. Now, this takes us to the quantitative aspect of the research. Now, I think you mentioned earlier distribution of ambulances. You mentioned that there were 19 healthcare facilities across Nakuru, and each facility was equipped with an ambulance, which was good. But then 7.2, the other point that I found, the other aspect that I found, the equipment and supplies, that one was a bit of a shame. There is no AED in the ambulance, nothing like that. So basically, it means that there's no ECG, because there's no AED. So there's no AED. Am I assuming there's no ECG? Am I correct? No ECG. So there's no ECG, no AED, nothing to monitor the heart or anything. So yeah, and then after that, there is no blood glucose monitoring devices. There are no pulse oximeters. There is lack of functional immobilization equipment, no radio communication, no PEE. So zero in all of that. I think you said 100%. That's how you put it.
Yeah.
Now, we don't have an ambulance there. Based on this, I'm not sure. Are there stretchers?
It is a very sad state, because the vehicles do have the names that they are ambulances, but looking inside them, I felt like it would be very inhumane to transport someone who is unwell in such a vehicle, because there is no, basically there's no medical intervention that you can undertake in some of them. And if the devices are not there, is one thing, but then I think there was one intermediate ambulance that had an AED, but none of those deployed using that ambulance was confident enough to use that. Actually, a good number of them say they have never operated that device. So I think where we are at the very basics. There are so many things that we will need to do. We would need to equip them well. And the other thing would be to train the users who will be using these devices on how to use them. It is a sad state, but it is the reality.
As I'm sitting here, do you want to say something, Tulani?
Can speak. Now, I just wanted to make a quick comment. Is that many countries beyond Kenya face similar challenges with poorly equipped ambulances and under-resourced emergency medical services, especially in low to middle income countries. I mean, if you look at countries like, I'm not sure if I remember correctly, Uganda is closer to Kenya. They found the ambulances lack some basic equipment where the paramedics never had equipment. Other countries like Zambia, um, mm, and what you guys are encountering is not unique to other countries as well. However, the fact that it's not unique does not make it right, because and I must be honest, I'm speaking from a place of privilege, and obviously I'm from South Africa, is that we quite privileged that although the systems have challenges as well, but we do have those basic equipment that we need. But also the confidence, which is something that I found it interesting in your paper, is that the confidence in using those equipment is quite high. Whereas if somebody doesn't have the confidence in using the equipment that they have, it's quite sad. And I always bring it to the heart of the patient, is that the people that need it the most may not even get the necessary treatment. If you can't diagnose, you can't treat. Like, for example, if you can't use like a blood glucose monitor, for instance, in a patient that has hypoglycemia, you can't even treat it. So that's what I wanted to say, is that it's interesting findings that you've highlighted, and we hope that and I think it goes to also some of the challenges that you said, is that lack of education, or people that are being educated in Kenya, especially in the EMS service.
Yes.
Yeah. So what I was doing here, look, South Africa has a lot of issues too. I need to say that we do have a lot of rural communities that do not have access to ambulance service. It may take hours to get there. It's not like we're trying to say that we're much better. There are big issues there. I always talk about Gogo Dlamini that has a problem. The Granny Dlamini who is stuck in the rural areas, who call an ambulance and wait for 12 hours to get an ambulance. I always talk about that. It's issues that are there. As much as they would know which number to call, but there are issues. But in terms of the SATS monitor, there are 19 ambulances there. And I just Googled here in Australia that they say the cheapest SATS monitor, saturation monitor with pulse oximetry, is $20, which is about 1,717 shillings, Kenyan shillings, the cheapest one that you can get, right? So in South African rands, to land, it'll be 200 rands, around 200 rands, to get the cheapest one. Now, I times that by 19, it says 32,623. That's not very expensive. I think a government can afford that, even put, I don't think that's it's like there's no money, we don't have money. Sometimes it's lack of knowledge. Yeah. I see you want to say something, Ben.
I think for me, what came out is the goodwill, the political goodwill is not strong enough. The people in charge of making the decisions that this is what we need are not making those decisions for whatever reasons. Then also mentioned in the paper is that the issue of ambulance has also been politicized, such that you would find maybe politicians saying that I am the one who has access to that ambulance. I decide where it is deployed to, or this ambulance. I have bought this ambulance for this community. So the politicization of this system also makes it very vulnerable to political issues, such that either it will not be funded well enough, or people are not so much interested as to how it performs, as more than just that the idea that, the community can see we have a vehicle that is an ambulance, and so they should be okay with that.
I think it all starts with just having one ambulance. and then equipping it properly, right? Just get one, equip it properly, have everything that you need inside the way that you like to, and get people trained into using that ambulance properly. And then you get a second one, a third one, and at the end of the day, you have 19 after that. And then after 19, then it can grow. I think Dr. Wachira mentioned that there was something that was similar to that they were trying out. As much as I remember that when he did shadowing in some other country where he wanted to see how the ambulance worked, he saw that the equipment that they were using was expensive. I do think that as compared to having an expensive ECG monitor with defibrillator, at least have a defibrillator and then know how to use it. Like, know that you need to. And the thing is with defibrillators, they actually talk to you. Plug in pads to patient, bare chest.
Yes.
Turn on the monitor, and then but pressing charging light, shock advised, that it talks to you, it tells you what to do. It's not complicated to use it. It's actually made for lay people to use and familiarize people with that. That's basic. Even I think that is one of the reasons a lot of countries ended up adopting the American Heart Association courses, because you can access it online, you can access the trainer, they can come to you, they train you, and then after that, you can just practice that and ensure that you stick to those guidelines. I think that's the basic of where it starts. I'm not saying that your country should follow American Heart Association, but if there is another system, they can follow it. But look, we do wish that things can be better in Africa, and the African people can be treated as other people in the world by people that lead them, by employing systems that function and that actually better their health. Because if you take care of the people at ground level, primary healthcare, ambulance systems, it means that you're increasing the lifespan too of the population. So longer term, it means that you are assisting the communities. Better healthcare systems, they increase the lifespan of the communities. It's actually good for the country. Anyway, thank you very much, Ben, for coming and being with us. We are rounding off now. Before I shut down, can I ask? I think Tulani wanted to say something before I shut down.
There was so much to unpack, as always, but we have to round up now. Ben, I just want to have a quick question.
Yes.
On I think the types of training. When I read the paper, what I came across is that there's basic life support, and it sounds like it's a 3-tier system whereby you've got basic life support, you've got intermediate life support, and also advanced life support. Is that correct, or how does the training work in the emergency care personnel training in Kenya?
Oh, that is not the training. That is more how the vehicles are equipped.
Mm-hmm.
So there's a vehicle that is supposed to be equipped only for basic life support. There's another one for intermediate, has perhaps more devices where a number of interventions can also be conducted. And then there's the fully advanced life support, which is not there in the county. For the training part, most ambulances, as mentioned, functioned with nurses because the paramedics that had been trained in the county were for some reason also absorbed into the clinical setting of the hospital because of understaffing. So there were paramedics that were trained to be running these ambulances, but they were absorbed into the hospital duties because maybe the hospital does not have enough nurses to carry out the normal work. And it is not every hospital that had paramedics. So I think if you look at the number of participants, the paramedics were very few. Yes, so the training is usually for the paramedics. For the drivers, most of them mentioned they have no education with regards to emergency care. And mostly what they do is drive, and this is also a huge hazard, because if you would want a driver who is also able to help you tackle the situation. If we tell them, okay, now we want to write an ECG, or now we want to administer this intervention on that, you want to have a person who is also able to prepare that as you, as a paramedic, engage into the decision-making aspect. So that is something the government has to look at, the training, so that the training is consistent, and it is also training for both people on the ambulance, such that one is able to support the other.
Okay, so look, I'm going to digress a bit. Is that obviously, I think before I started the paramedic training,
Yes,
in South Africa, I knew that there was someone called an ambulance driver, and obviously
yes,
as a medic, and someone driving fast with the lights and sirens as a kid looked cool. But now, fast forward to 2025, there's no way I would want to to have an ambulance driver, and mainly because of the reasons that you've highlighted.
yeah,
If you've got a critical patient, you need someone that is competent, that is trained, that it's either at your level or might be at an appropriate level to assist in managing
yeah.
that patient. So it's quite important that that people, you don't just have ambulance drivers, but people that are actually trained to work in those emergencies. But yeah, I've got more, but because of time, I won't.
Yeah. Okay.
Yeah. Thank you very much, Ben. We appreciate your time. I know you're working night shift. Go and get a nap, and we really appreciate the work that you've done. I do hope that it lands to the right ears, and something is done for the people of Kenya in Nakuru County. Thank you very much.
Thank you for having me, and we hope for the best, not just for Kenya, but for all countries across Africa.